We hosted this same webinar on Tuesday, and I think from what you could see in the invitation, this is really aimed at connecting you as implementers and helping you to exchange with one another and learn from each other about what adaptations you're currently using at the field to ensure sexual and reproductive health services in the period of COVID-19 response. And we really hope that this is an opportunity mostly for you to connect and share and feel the support from one another, but also to help us as IAWG in our efforts to provide support during this time. And I think we're going to be learning a little bit about what resources IAWG has already developed and some of the activities that IAWG engages in to support implementers in emergencies like this one. And so we really hope that from what we learned from you today, we can strengthen our ability to do that work. First, I wanted to talk a little bit about what IAWG is. And so I'm going to start sharing my screen with you. And I'm going to invite a colleague, Sandy Krause from the Women's Refugee Commission, to tell us a little bit about what IAWG is and how we support sexual and reproductive health service delivery in crisis settings. So I'm sharing my screen. And Sandy, I don't know if you can come off of mute and join us.
I'm here, Ashley. Thank you.
Hi, Sandy.
Hi, everyone. Hi, Ashley. So in minutes, I guess I'm going to give you the who, the what, and the how of IAWG, just brief overview. IAWG was established actually 25 years ago in 1995 by the United Nations High Commissioner for Refugees, the United Nations Population Fund, WHO, a number of governments, donors, and obviously international NGOs. Today, the IAWG Secretariat is hosted at the Women's Refugee Commission, and it's under the leadership of Sarah Nestor and supported by Alison Greer, who leads the IAWG's Training Partnership Initiative, as well as Rose Bender, who's the Digital Media Manager for IAWG. But IAWG is actually governed by 21 steering committee member agencies, again, from relevant United Nations agencies, as well as development and humanitarian organizations. It's also supported by an additional 22 associate member agencies, also representing humanitarian and development organizations. So what does it do? It develops technical guidance and global standards. One of the very first things it did was establish the Interagency Field Manual on Reproductive Health in Humanitarian Settings, which addressed comprehensive reproductive health, but also for the first time, the manual was put forward in 1996, the minimum initial services package for sexual and reproductive health, designed for the acute phase of emergencies. And more recently, it's established COVID-19 programmatic guidelines as an example. The IAWG also works to build the evidence base and support learning about sexual and reproductive health in crisis, and has undertaken global evaluations every 10 years, 2 decades in a row here. We have one on the horizon in 2022. It also establishes and implements a research agenda. And it undertakes advocacy, amplifying sexual and reproductive health needs in humanitarian settings, and of course the funding priorities for that, and works to promote accountability. But how does it do its work? Well, IAWG, the steering committee members and associate members and even some individual members participate in 12 different working groups of IAWG. And these working groups are based on the thematic areas of sexual and reproductive health and cross-cutting issues such as supplies and logistics, and population groups such as adolescents and LGBTI populations, and also preparedness as examples of kind of cross-cutting areas. So these 12 sub-working groups update an annual terms of reference based on what's been accomplished to date and where the gaps stand in each of those thematic working groups. And so that's how the agenda is advanced annually. With that, back to you, Ashley.
Thank you, Sandy. I knew you were the right person to give the right flavor of IWAG. Sandy is one of the strongest leaders within IWAG, and so I knew it would be the best placed person to describe it for us.
Thank
Um,
you. It's a
yeah.
long-standing one, that's for sure.
um, so I'm going to take us through the agenda for today's webinar. And as I mentioned, we hope this is something a little bit different from some of the other webinars that you may have been participating in recently, particularly related to COVID-19. I know there's been a lot of information coming out, a lot of guidelines, a lot of really incredible analyses and expert technical resources that have been put out. But we actually really want to focus a little bit on that, but focus more on connection and exchange among implementers and hearing from one another. So we're going to do a very quick overview of some key IWAG resources related to COVID-19, just so that you know that they exist and how you can access them and how they might be useful to you. And then we're going to break into small groups so we can talk about SRH implementation during COVID-19. You're going to get into small groups with a facilitator and have a discussion about solutions, challenges, and how we can, as IWAG, can help to further support your connection with one another and your access to technical guidance and advocacy that we can be doing on your behalf. And as I say here, what comes next, we really want to use feedback from this webinar to inform future webinars and other ways in which IWAG can support you. This could include both informing our advocacy, technical guidance materials, but also maybe new ways that we can be building learning around these adaptations and helping each other learn how to put those into practice. So that gives you a little bit of a snapshot of what we're gonna do for the next a little over an hour now. We're gonna start with both giving you a snapshot of some of those key IWAG resources. So the first one that we're gonna talk about, I'm just going to give you a very quick snapshot of the programmatic guidance for sexual and reproductive health in humanitarian and fragile settings during the COVID-19 pandemic. And not to go too much into this resource, but just to tell you that it's available to be for you to download if you haven't already seen this before. It's an excellent and very practical resource, and it's available in several languages on the IAWG website. But a few things about it. It was developed by technical experts to help programs in making difficult decisions about what essential services to keep in place and how to keep the essentials of sexual and reproductive health going, despite all of the barriers that are in place because of the COVID-19 pandemic. And this was also really informed by the experience from the Ebola outbreak, which really demonstrated the really dangerous consequences when access to sexual and reproductive health services are significantly curtailed during a public health outbreak. The consequences of that can be almost as devastating or more devastating than the actual consequences of the outbreak itself. So this is really to help you as implementers understand some best practices about what should be continued, what are the essential things, and actually some of the considerations when making difficult decisions at the field. And this is, as I mentioned, available in several languages and will be updated as evidence evolves, and also informed by practice at the field as it's being used. So I'm also now going to invite my colleague from CARE, Anushka, who is going to tell us a little bit about the CARE IRC Global Rapid Gender Analysis for COVID-19, which I think helps all of us to understand some of the very specific implications for women and girls in COVID-19. and how we can apply some of that learning into programmatic decision making moving forward. So Anushka, I don't know if you can come off mute and take us through some of these findings.
Thanks so much, Ashley, and thank you to IAWG for organizing this. Like Ashley said, I will be speaking briefly about the global rapid gender analysis undertaken by CARE and IRC for COVID-19 in mid-March 2020. And I will just go through some highlights of the global rapid gender analysis, but the full report is available online, including recommendations. We've also done regional level rapid gender analyses and some country-specific ones as well. So please, at the end, we'll share the links to all of those. So maybe just to begin with, first, what is a rapid gender analysis? It is an assessment that examines changing gender and social norms before and after a crisis. The reason this is important is because we know social and gender norms and power dynamics can have a significant impact on accessing humanitarian services or aid. So for example, a woman whose mobility may be restricted because of the decision-making of her husband before a crisis may then become further limited due to insecurity or lockdown, which would then further restrict her access to sexual reproductive health and rights. So with this in mind, the rapid gender analysis relies on primary and secondary data and is developed through an iterative process and therefore building upon each other so that it can really, so it's really actually imperfect, but it is speedy and practical. With this in mind, CARE undertakes rapid gender analyses at the beginning of every emergency to inform practitioners, policymakers, donors, and other stakeholders to consider and program for barriers and opportunities, coping mechanisms, and changing roles for individuals across genders, age, and other intersecting factors that may contribute to their exclusion or marginalization, such as disability, social, sexual, or gender minority groups, or refugee or migrant status. Next slide, please. So first, I'll just talk a little bit. So I'm going to divide this into two key parts. One is first the cross-cutting findings and then some sectoral findings. So in terms of cross-cutting findings, just highlighting that even though statistics indicate that the elderly, in particular men, experience higher rates of severe illness and mortality associated with COVID, women and girls and other vulnerable groups are also at risk. In fact, they experience disproportionate secondary implications of the health crisis due to gender roles, responsibilities, and social norms, including the division of labor both inside and outside households, paid and unpaid work, access to and control over resources in the household and community. We also know that globally, women perform 76.2% of unpaid work. That is actually 3 times more than men in general. And this, of course, is even more concerning in places where there are weak health systems that, may not have the capacity to attend to all COVID cases, which would then place additional burdens on home-based caretakers. And this, of course, also increases women's exposure to COVID. So next, just moving on to, sorry if
I advanced too quickly. It was
okay.
got away from me.
Okay.
Sorry about that.
No, I thought I was having technology issues. Okay, sorry. Moving on. So, and then finally, just also highlighting that we also really want to think about women's leadership and decision making. We know that globally 70% of workers in the health and social sector are women, but over 70% of CEOs are male, including in global health organizations, and only 5% of them are women from low and middle income countries. Similarly, women's frontline interactions with communities and women's socially prescribed care roles place them in a prime position to identify outbreak trends at the local level. However, we know that in humanitarian crises, women and girls are often excluded from community-level decision-making processes, governance structures that shape the response, and of course are often not incorporated into the global health machinery and coordination mechanisms. Next slide, please. In terms of sectoral findings, again, just to highlight a few key ones, most relevant to this group, we know that gender-based violence increases in any crisis, and this was confirmed even from the early days of COVID, flagged by women's rights groups. We know that there's a significant impact on lockdown and violence in terms of individuals, particularly women, being trapped with their abusers. We know that there's an impact on access to GBV services related to loss of income, lack of information, and fears over contracting the virus at service points, which then create multiple barriers to access. And of course, this is compounded for groups like migrants, homeless populations, and sex workers. Availability of GBV services, both prevention and response, may also be weakened due to court closures and safe houses. We also know that sexual exploitation and abuse is also likely to increase, and an overall economic downturn impacts food insecurity and loss of income and employment opportunities, which can also result in a spike of sexual exploitation and abuse. And then we know, of course, that in terms of sexual reproductive health and rights, we know that any public health crisis not only results in continuing, but also increasing needs when it comes to sexual reproductive health and rights. And what's even more concerning is that sexual reproductive health and rights is at risk of being deprioritized. We've seen this in other crises, and we're seeing this again now. The evidence from the West African Ebola outbreak saw that NGOs and non-Ebola health services closed across the region that was affected. This resulted in reduced access to family planning, increasing the risk of unplanned pregnancies. We know that the closure of maternal health clinics also impacted maternal mortality significantly, and that school closures led to an increase in sexual activity, which disproportionately affected adolescent girls. Of course, the scale of COVID-19 is even more significant, impacting the entire world, and this diversion of resources has even more tremendous impacts. We know that with pregnant women, even though the evidence currently is saying that the focus is more around around the disruption of health services, which is really concerning in places where already there is so little access to emergency obstetric newborn care and other life-saving services. So again, just really highlighting the importance of thinking about these exclusion factors and the additional gender and social norms that restrict women and girls' access to services in line with the MISP, life-saving essential services in line with the minimum initial service package for sexual reproductive health in crisis. Moving on to the next slide. So I won't go into the recommendations. As I mentioned, these are all highlighted in the report, but really, emphasizing the importance of continuity of care as it relates to the MISP. You can, go ahead and go through the report for additional details. Finally, the very last slide just shows, some of the links where you can access these resources, again, at the global and regional levels. In the interest of time, I will pause there, but happy to share these moving forward. Thank you.
Thank you, Anushka. And I'm hoping that you highlighted a few of the key themes and programmatic considerations that I know are likely playing out in some of the places where people who are joining today, some of the participants, they're seeing some of this play out in their work, and hopefully we can use the small breakout groups to discuss some of this in more depth. I finally wanted to, in touching on an additional IWG resource, and really speaking to the kind of the third pillar of what IAWG does is really around advocacy. I'm going to invite my colleague Sarah Rich from the Women's Refugee Commission. She also leads the IAWG sub-working group on contraception, to talk a little bit about the IAWG advocacy brief, which is just minutes away from being released, and hopefully will help not only to strengthen global advocacy, but also will be used in a number of different ways to support country and local advocacy as well. So Sarah, I'm going to hand over to you.
Thanks so much, Ashley. Yeah, so prior to Anushka speaking, Ashley presented on the technical guidance that the IAWG developed. And as that technical guidance was underway, the IAWG also identified a need to develop advocacy materials that would ensure that those of us who are working within the SRH space, particularly in humanitarian settings, are continuing to elevate the importance of sexual and reproductive health services as essential services, and that these services, that there is continuity of sexual and reproductive health care in humanitarian and fragile settings. The advocacy, the IAWG advocacy and accountability subworking group, a subset of us kind of came together to start to draft some language, and that was really led by Siri May from the Center for Reproductive Rights. And we identified that we also needed to use the advocacy statement to elevate experiences and concerns from frontline providers, and that the statement needed to target a range of key stakeholders, including governments, donors, UN agencies, humanitarian actors, etc. So the advocacy brief is a 3-page document that provides some context and then includes a very substantive call to action with some detailed recommendations in these areas that are listed on the slide around delivering the MISP, funding that delivery, supporting better coordination, ensuring access to SRH supplies, supporting women and workers on the front lines, and ensuring accountability for marginalized populations. The advocacy statement went through quite extensive technical review, including from some of the other more technical IAWG subworking groups. So the advocacy group is hoping that now that we have this 3-page summary document, this 3-page document, that we'll be able to pull from that to develop other advocacy materials as needed as the situation continues to unfold, and in particular as we continue to get feedback from frontline responders, like some of you who I think are on the line today. So the advocacy statement is scheduled to be released on Tuesday, along with some higher level summary language, so that will become available to everyone. And the group that's been working on that is quite interested in continuing to hear back from folks who are on the front lines to understand what the advocacy needs are on an ongoing basis and to make sure that we're responsive to them. Thanks.
Great, thank you, Sarah. That's great, and I think that further, I'm glad that you mentioned that. You know, one of the goals of today, and one of the sort of ongoing goals of the IAWG, is to make sure that we're really informing all of the other pillars of what IAWG does: the production of technical guidance, generating evidence, and advocacy is really informed by the needs on the ground, and we can hopefully be doing that in a much more consultative and in real time as much as we can, which I think kind of brings us to the next part of our discussion today, which will be to break out into smaller groups, where we will have some facilitated discussion. We assigned everybody to one of 4 breakout groups in one of 4 thematic areas, and this was really based on the way that people responded and what they were interested in when they registered for this webinar. So we have a group on maternal newborn health, one on advocacy, one on adolescent sexual and reproductive health, and one on gender-based violence. And when we break out into the rooms, Zoom will prompt you to move automatically to a room, and in there you will meet the other people who have been assigned to that room, and also your facilitator and another person who will be capturing key themes using an app called Mural, and you'll get to see sort of how this works. We think it's a really interesting way to capture and sort of replicate the experience of being in a workshop in real life, which we can't really do anymore. We will not come back to plenary. Your facilitator will conclude the meeting from your breakout room. And just to say, if you've been assigned to a breakout group, which doesn't completely match with your particular area of interest or expertise, just feel free to share about what is your particular area of expertise and related to how you're responding in COVID-19, and keep that's fine. This was just to kind of keep some focus to the discussion, but please feel free to describe things that are outside of that particular topic. And I think it's really important for us to share with you now how we plan to follow up from these discussions and from this webinar. We will share an immediate readout of the themes with participants, likely within the next week or so, with some more in-depth analysis. And really, we're using this to inform the ways that we can conduct additional gatherings like this one, and really more tailored to what the needs are that you're expressing. And these could also be more aligned with particular technical areas. We hope that they can also be more regionally aligned or country aligned, based on the appetite and interest from participants who come to these webinars, and also other ways that we're gathering that type of information. So we will be broadcasting what's going to come after this, both through the IAWG website, and then also through the listserv and other ways, and hopefully sharing that through social media and other ways that we can disseminate this information. We also want to hear from you today about ways in which we can bring other people into these discussions, get more participation from frontline providers who might not really have the opportunity, frontline providers and program managers who maybe don't have as much opportunity to participate in these types of sessions, but whose input is so important and valuable to the support that we can provide moving forward. So we are going to move into the breakout groups, which will just maybe take a few minutes for you to get settled into the room. So here's a few questions to be thinking about as you move from plenary into your breakout room, really around the adaptations and solutions that you are currently using to maintain SRH services, some of the barriers and challenges you're facing to reaching clients and providing services. What support do you need to address these challenges and develop solutions? And finally, what communications channels are working best for you to get information and to connect with other implementers or with other technical experts? So just keep those questions in your mind, and what's going to happen now is that you are going to magically be whisked away into a breakout room and meet your facilitator and your small group participants there, and continue this in more of a discussion format. So I just want to thank you so much for your attention during plenary, and hope that you continue the discussion and have a really meaningful exchange in the breakout groups. So thank you so much. So just be a little bit patient as you settle into your breakout groups, but here we go.
Hi everyone, my name is Rabkam Salu. I am a senior advisor at Save the Children, and I will be facilitating the maternal and newborn breakout room with Kate Ramsey. Kate, do you want to introduce yourself briefly?
Sure. Hi everyone, I'm Kate Ramsey. I'm a senior global health advisor at Scope, which is a social impact company based out of Finland that uses human-centered design to tackle sexual and reproductive health problems. Thanks, Rivka.
Brilliant. Okay, so the session here is primarily going through the 4 topic areas that Ashley mentioned towards the end of the plenary, really looking at what we can learn together and share among ourselves on program adaptations and innovative way of working that you are using in your country programs or field programs, the barriers and challenges that you are facing with COVID-19 and the potential indirect impact it may have on access and use of maternal newborn health surveys. And then we'll go into solutions on how we can collectively work together to find ideas and innovative ways of addressing and maintaining surveys. Towards the end, we'll look into